introduce you to the genius system, advanced genius system. We'll talk about the innovations. Yeah, we'll talk about what is in what's the future is in store for us in the future when it comes to the advanced genius system. It is all about going beyond. So, hello everyone. My name is Emeric Augeraud. And what I would like to say today is that on a daily basis, we need to reassess what we are doing. And we are always trying to reach new targets. We are always trying to reach new excellence targets in order to be the best possible in our procedures. We also try to improve the best way possible the patient journey. And we try to ease the best way possible the journey of the clinical team. It would be the three main elements, the three main targets that we are trying to reach on a daily basis. We are trying to also reach new goals thanks to digital tools, because it would be the best way for us to reach new targets. Also different sectors, and the medical sector in particular, are using ever more digital tools. So it is a quote, I don't even remember who said it. What I can say is that it's not mine, but it is mentioning that artificial intelligence won't lead to orthodontists' disappearance. However, orthodontists, also few orthodontists will disappear if they don't use digital tools and artificial intelligence. So we managed to see many cases showcasing many wonderful treatments provided by Ephraim, with Dr. Labidbi, El Koubi, Medina, Koleilat. I don't remember. I think it was Sasha Job also provided wonderful examples of treatments that he provided. And I would like to ask you a question about that. What would be the keys to success for a genius treatment? Ali, just think about three different keys to success for a genius treatment. Just have a broader view of the situation. So bonding is important. The diagnosis, sequencing, and the orthodontist per se. Okay, so you say the orthodontist is important. Use strategy is important. It could be the equivalent. The brackets are not a silver bullet. You need to have a specific treatment strategy. You need to think thoroughly about what you intend to do before doing it. So it comes from your own mind. You are the one preparing the treatment plan, but don't fool yourself, because in the future, the digital tools, the artificial intelligence will do it for you. For example, companies such as Iceland managed to get hundreds of millions of euros in order to provide such tools. And tomorrow it will be the case. Someone else, artificial intelligence, will do it. You've not talked about patient cooperations. And last but not least, there is also the genius system. Those are the main keys to success for the treatments which were presented until now. So, dear doctors, those who presented your cases, you presented a few cases which were very cooperative when it comes to elastic use. So when it comes to the genius system, we need to focus on bonding, the wire sequence, the timing of the wire usage, and the auxiliaries such as the elastic and the wedges, in order to optimize the different shifts and positioning in the mouth. We would like now to focus on bonding and wire sequencing. We would like to innovate on that. When it comes to the bonding of the genius bracket, you've talked a lot about the height bonding guidelines. Every one of you have different height bonding, and you are comfortable with different heights. I mean, for some of you, you are more at ease with specific bondings at a specific height, and for others, it would be on another space. And it depends on the case as well, and the bonding method. So beforehand and until now, what was happening when it comes to the bonding methodology? I just provided some sort of a caricature of myself. And maybe some of you will recognize themselves in this caricature. And it doesn't work. The movie doesn't work. Sorry about that. I'm clicking on play. I click, and the film doesn't start. What should I do?
La vidéo, oui, elle est, c'est-à-dire
Ah, here it is. It's working. Unfortunately, the interpreter can't hear what's going on in the film. So here he was dealing with the gauge. So of course we will forget about the gauge. And now I'll need you. I need you again because I can't manage to start the films by myself. But I would like to explain what he's doing is just moving the mouse while clicking. It is very specific methodology. Apparently, he's an expert. Oh, we were so close. What did you do? And now we lost the sound system. What a marvelous world. Okay, but don't worry. I do it live. I don't need a film to support what I'm saying, to back what I'm saying. Okay, don't move us anything. Oh, no, we can't hear a thing now. What happened? I mean, it's because of Windows. You know how it is. It's Microsoft.
Okay, never mind. Okay.
Okay, so what I was trying to explain is that when it comes to bonding, you have the mirror, you will have your tooling. What do you think of the bracket? What should I do? Oh, maybe we should just shift it 5 degrees on the left or on the right. And it's a little like this. We are like bonding artists. We are positioning it differently. We're using the mirror. Oh, yeah, the positioning looks perfect. But we always feel like that if we shift it a little bit, it would be even more perfect. But at the end of the day, it is as if we were craftsmen, you know. It is something that is not done that perfectly at the end of the day. And most of the time, we need to reposition the brackets or rebond them. Each time you were presented cases beforehand, it worked because the strategy was great, the patient cooperation was great, and the bonding precision was on top. Because if all those criteria are not gathered, it won't be possible. So what will happen tomorrow? When I say what will happen tomorrow, I'm not talking about next Monday, but in the future, what will happen in our practices? In order to improve our experience. When we're bonding something, we're not bonding at a specific height, we're bonding the bracket depending on what will be the perfect future position of the tooth. I don't remember which stupid American guy said that. But also, I would like to bear in mind that we need to have a digital working experience with the clean check. We know that a few people are working a few hours per week at home in order to perfect their clean check. So we need to ally those two elements and to think about the way we could improve and the way we could provide an indirect bonding digitally. And it is called the Genius IndieBound system. So we are using trending words such as the digital workflow. I went to Cologne recently, and everyone was talking about the digital workflow. Like 90% of the of people were talking about that, about Cologne. So we will need to enter the treatment plan on the computer. Then there will be printing on what we will do at home or in the lab, depending on if you have the right devices or not. And then we will provide the indirect bonding. Hence, you know that it looks like what you already know with the aligners. It is the exact same process. And now we benefit from a wonderful support system. If you don't want to have the devices at home, you can have the Auto Partners devices, which are Ruelle My Maison in France. But it could have been in Dubai. It would have been the same. You have the same access to it. So here is not a case presentation. I'm just here to talk about the way you can bond digitally those brackets and the benefits of it. So let's take the example of the Class 2 to Division 2 patient, a very classic case, nothing special. She has a slight gummy smile, I mean, nothing major, no need for an extraction in the treatment plan. The panoramic X-ray is still interesting to look at because we all know that we will need to have distal movements at the root level of the few teeth. It could influence the bonding, and then there is a profile X-ray, which is not providing relevant information for the treatment plan. Then we need to have the digital impression. It's not a digital print because it's not a digital print. It is as if you were in a police station because you committed a crime. I mean, at least in French, it is a way to talk about it. It is a way we call it a digital print. But this time I'm talking about another kind of digital print. And then we will send those pictures to the lab. And the lab, in turn, and the software or the software company, how do you call that, the lab? I mean, I don't know, who cares? Independent will send us this setup. So we end up with a setup with lines, crosses, and everything. And afterwards, we need to choose the brackets. So you choose the brackets you would like. So on the database, there are also, of course, the genius brackets available, the crystal brackets, all kind of brackets you want. Each time, the moment you choose a bracket, instantaneously, depending on the setup, the brackets will appear. And it is when it becomes quite interesting, because the setup will be the way to determine the bracket positioning. It is different than what we're doing on a daily basis, which is bonding the brackets in order to reach a specific result. We are doing it the other way around here. But what is interesting for us is the final result. I don't know if you remember that, but I would like to make a parallel with what Ashley mentioned. Was it Ashley? Yeah, Ashley. Yesterday. 2 days ago, he didn't talk about the treatment process to the patient. He talked about the final result. The patient is interested in the final result. He doesn't care about the journey. So we end up with that. If I want to make a relation with Invisalign, who would like to validate a clean check without modifying it? No one would do that, except for the X-price category, which are quite simple to deal with. There is always shift and modifications to do. So here we have just worked for 2 seconds. We have just chosen the brackets. What we'll do now, I would like to show you a film. I hope it will work, because I will be quite annoyed if it does not work this time. There are many different methodologies. If you want to do it the old way, you can change the bracket positioning, which will, on the right, change the position of the tooth. If, for example, I think that the central incisors are a little too, there is a too important intrusion of the central incisors, I will need to put my brackets higher. So let's see if the film's working. Doesn't it work? Well, oh, it's not funny anymore. I don't understand why my films can't be launched. No, but the mouse is working perfectly. I don't understand what's wrong with the system.
I just want to launch a movie. I don't need the sound. Sorry. This one, it's actually this one. 23, slide 23. Right. Okay. Iceland is beautiful, but... Ok, here we go. Donc, voilà, regardez. Je clique donc... Ok, je clique sur un bracket.
So, for example, if I click on a bracket, let's say that I click on this specific bracket. I was filming everything at the same time, so I was quite slow. So let's say that I click on different brackets at the same time. I will click on the bracket tab, and let's say that I put them higher. You can see that on the right, the teeth are getting, will be inclined. So I'm not saying that I don't care about the bracket positioning, but what is interesting for me is the final decision. So I took just any tooth, and then we can see that the bracket will go down. here, for example. So it's not even about bonding willy-nilly. It is about the fact that we need to bond with a specific goal in mind. And here, let's say that I would like to have a mesiobuccal rotation for this cuspid. If I do it with the arrow there, you can see that at the same time, the bracket will reach a more mesial position. It is exactly what Ephraim said beforehand. So what is pretty crucial is that the anterior bracket position can depend on a global height, but one next to another, it will depend on the final result we would like to reach. It will be our main guideline. What would be the final result we would like to aim? The position of the central incisor compared with the lateral incisor, and the global position. Should it be? Should we have an intrusion, an extrusion? How should we limit the gummy smile, and so on? So what's happening here? I feel like it is the same slide. Okay, that's okay now. So here is particularly important. When it comes to the incisors, I would like to insist on that. When it comes to the correction of the incisor rotation, it will depend on the way. And it is kind of obvious. We can center the bracket depending on the mesial and distal edge of the incisor. So here, for example, on the top right, the measurements are quite specific, and it is a way to validate that we are the perfect centric position. If the position is central enough, the position of the tooth will be corrected. It is compulsory. It is just a mechanical consequence. So if you want to optimize the rotation correction, when you use the 1925, for example, you can use a chain, because the chain will pull with the same traction on each side of the tooth, and it will recenter the tooth. You shouldn't forget that there is a leeway between the size of the thread and the slot of the bracket, which means that you can have micro degrees of rotation which might not be corrected. If you turn the chain a little bit, the rotation could be optimized. So let's go back to the software per se. If we notice that the class 2 is not completely corrected, you can just move the different arches thanks to a click. Once we reached this final position, you can have a look at the way the upper teeth have a collision. There is a bracket collision. And it is exact same way you do things when you are doing bonding, the bonding appointment. But here it is on the software, and this is more specific. So you select here all the teeth. So for example, you have on the 37, you click on Shift, you go towards 47, and all the lower teeth, all the different brackets on the lower arch will be selected. Then you just need to use the arrow, and you will shift the bracket position in order not to have contact anymore between the upper teeth and the brackets. So let's say if I want all the brackets to be further away from the upper incisors, we know that the brackets will go into the gum, so it could be an issue. Apparently there was an alarm which just went out, and I'm sure that this participant was afraid to fall asleep during my presentation. So here you can see that if there are two brackets which are in contact with one another, we can allow to just put the bracket further down, a few millimeters down, in order to optimize the situation. However, another solution would be to add by turbo. So I will add turbo supports in the bonding retainer. And here, with the IDB tray, you can launch the manufacturing of the retainer, which will be needed in order to bond everything. So you can see that the material per se changed a lot, because it is where the brackets should be inserted for the lab or directly in your practice. You can either open or close extraction spaces or open spaces for implants. You can reverse the brackets, such as it has been shown by Dr. Labidi, if you want to have a reversed torque for an inverse lateral incisor. If, for example, you use a 4x4, 3x3 brackets, you can have the right lists. If you want to have steel brackets, ceramic brackets, 5x5 brackets, you can make a list, and you can also have pre-programmed bonding height lists in order to limit the modifications. It is what is called the clinical preferences. When they are overbites, when they are open bites, or when you would like to correct gingival smiles. You can also, afterwards, you can deal with the right height in real time. And there's also something which is quite important. The final position will depend on the real expression of the torque, especially on the posterior side. So what would mean the final consequence of the torque on the tooth? So we're dealing with the torque on the bracket, but what else could be taken into account? So I've not mentioned it, but I've heard the height. What else? What do you mean by that? The dimension of it, something else? The thickness, yeah, it was mentioned. Yeah, you're right. So the real slot dimension, it means that we are not dealing with a slot dimension which is showcased on the packaging, as it is the case for a few brands. At Genius, we are lucky enough to benefit from specific sizes. For those who participate in the conferences we have been organizing for the past 7 years, you know it. Even though we noticed it for the past 5 years that the dimensions that we propose are perfect. It's not exaggerated at all. We've noticed about the vertical position of the bracket, the final dimension of the wire, and the arch shape. The wider the arch shape is, since there will be a leeway between the brackets and your teeth, the more your teeth will move that way. So they were intelligent enough in the software to provide those features. You can see that there are different arch shapes. You can choose the right shape. You will choose the final wire you would like to use. And you can also click on the torque expression that you would like to have. If you click on torque expression, it will position the tooth depending on the arch shape, the dimension of the wire, and the size of the bracket. It is quite specific. It is rather different compared to what we're doing usually. Then when it comes to the posterior bonding, what is crucial for that? I'm talking about the difference between one bracket to another. It will be the leveling of the marginal edges. We are bonding based on the marginal edges. It is the way I do it, actually. So here you have the marginal ridges. And the network will show you where the marginal ridges were not leveled, and you will know where it should be leveled. If you want a specific bonding, it will be necessary. Then the bite, the occlusion, is crucial as well. So if it is a class 1, we won't have elastic. But if the patient is a class 2 patient, he will use elastic and end up being a class 1. But you can still work on the bite, on the occlusion. The software will show you where the strong occlusion bite you need to abide by if you better approach the bonding. And you can manually provide an intrusion, which means that, for example, shift the brackets a little bit in order to limit the contact. So also you can have uniform occlusal contact, which is a methodology which is provided directly by the software. I think that you need to click on occlusal collision. And if you do so, the software will show you where the contacts are too heavy or too strong. And then you need to click on UVC in order to limit the contacts. And then you will level the brackets the perfect way in order to limit the contacts. Here you can see that there is a CBCT integration to the setup. It is mostly to work on two different things. Just to put it in a nutshell, we would like to limit the root canal proximity and the torque defects.
On a, on a la gouttière de collage, on est prêt pour coller.
Well, we are ready to bond.
Je crois que je vais... Oh, il fait 1 minute le film, de toute façon il passe pas les films.
I'm not able to show you any videos anyway,
Comme ça je voulais pas le montrer, ça tombe très bien. Non, never mind.
so I'm not going to show it to you.
Ok, mais elle l'a montré l'année dernière et je crois que...
We showed it the last year.
Si je ne m'abuse, le collage en Genius ou en...
The Genius bonds.
Comment dire, pour avoir des bons résultats...
In order to obtain good results, you must use a Genius system. It's really fundamental.
J'ai changé complètement et une nouvelle séquence de vie, j'ai changé mais...
I changed everything. Now I make an appointment in digitally. I send pictures. Of course, the patient may have questions. No problem with that. What we are going to show is one picture says more than 1,000 words. And of course, I can delegate tasks to others. I change the wire and I advise the parents on the spot that I am responsible for the results of the treatment, that I have made all the bonding digitally already. But I must not say I all the time. It doesn't make a good impression. But still, I must say it. It must not become too abstract for the patient to understand. I have appointments every 3-4 months, or even 2 months if needed. Well, all this stands to reason. I must go a bit fast because Ephraim must have some time. I communicate with the parents by meeting them or by zooming to them or by writing. Sometimes they are not interested. They just send the babysitter. They don't necessarily have to see the whole thing, the whole shebang every time. They have seen it to begin with, so it doesn't need to be complicated. I can send all kinds of images to the parents. I can send them this one, for instance. I had such brilliant films to show you. What a pity. We have a function, we click, animate, and then it all goes live. That's really brilliant. The parents and the patients, they think it's brilliant. They know, they can tell you have done some work. I have been working for 20 years, and this is really brilliant. Well, it seems to work. I send them this, aligning and whatever, and I send this. This is a case. I'll deal with it very briefly. I have another one, a better one. This patient, for instance. This is a case of DDM. He has a canine, the 43. It is very badly placed. And in this case, I will go forward with my treatment, but I told the parents that I could maybe stop and extract the wisdom teeth, etc. This is not really a strategy. This is a plan. I do a bond of both arcs, and it's 30 minutes. After 2 months, I clean everything up, and after that, I can see him every 4 months. In this case, after 4 months, I take off the second wire. 3 months later, I go over to 025. The wire must fill the space. Well, this technique has been very soft for me for years. So I skip this, and this is where I start with the elastics a bit. After 10 months, I re-evaluate the situation. I look at the smile, whatever I do, whatever extractions would be necessary, other micro screws to put. Well, and then finally the final elastics. I am going to. We could make a scan with the brackets in place, and see the difference between the patients after the 1925 and the order of finishing wire. That would be fine. You can go quite far digitally in foreseeing things. But we find a method that is easy and fast and efficient. This is the bonding. This is the final setup. These are the images I work on, and these are the ones that I can show to the patient. Here I exceptionally bonded the 43. I wanted to test it. Often I just put a spring to avoid secondary effects. And then I use the expansion. I think it will be evaluated. There is no measure, but we can appreciate it. This is the day of the bond, 014. I will leave it for long. No elastics. 4 months into the work, I saw him after 2 weeks 2 months to control the hygiene, and here the parodont worked very well near the gums, and I have lost a bit the first class because of the biting of the here I use class 2 elastics. Sorry, there is an error here. I must change this. This is the same sequence of wires, and you see the bonding here. I'm done with the bonds, and here We have the arts, and this is quite in line with what our colleagues have shown you already. This was my first bonding with Indibond. Now I will finish on on the collage with on the bonding with digital. And imagine that you only work digitally. Well, it must cost something. There must be a bill at the end of the day. The appointments are much shorter than before. It's very easy to plan to make plans and schedules for new patients. We can delegate to assistants quite easily. The delegate is less expensive than the expert. The results are satisfactory, and there is less finishing work to be done. All this is money. You spend more time on the computer and less time in the chair. It can be difficult to bond the teeth that are in evolution. You can start the treatment on what did you want to become when you? Well, there is no future for this for this profession. These are the inconveniences. Well, I have told you about the inconvenience. The patient can see the result beforehand, and the treatment is much better, more quality. The appointment is shorter in order to do bonding, and it's less constricting, and you don't have to wait, and my assistant might be able to do the bonding, and so you can. This is important to be able to show the results beforehand, and you make the patient confident when he sees the images, and you spare time and less appointments. I mean, this is really economically very advantageous, at least for those practices who with a great turnover. If they are beginners, they must be precise. I want to thank Indibond Task Force, Catherine Lavernas. She has jumped into the subject, and Ephraim, who is very active, and those three who are not here today, and Julien, who has been a great help to me. He is really nice, a great guy, and Charlie Elkobi, of course, and François Hérion. I want to thank all these people. The masterclass, there will be a masterclass. We will take people by the hand and lead them through genius step by step. And Bilal has talked about this yesterday. The 24th and the 26th of February, I can't do it then, but I will talk about this. I thank you. I leave the floor to Ephraim.
I'm delighted to be here with you. Thank you, Charlie, for inviting me. And I would like to highlight as well that I'm delighted to be nearly the end speaker, because it gave me this opportunity to see what was shown beforehand. It was wonderful. So I would like to provide some sort of a conclusion, some sort of a synthesis of what I've heard. Because what I would like to do is to see where we're going with our go beyond stuff. What I would like to do now would be to talk about the arch sequence. I would like to talk about indirect bonding, and I would like to talk about the fact that we need to be as efficient as possible to go further. I would like to be really down to earth and start with basic elements. Do you really know the forces developed by your arches? Because I'm pretty sure that many people here are not using a 0.14 thermal ultra to begin with. They will use a random wire, which will be more or less expensive, that they trust without even knowing what kind of forces developed by those arcs. So I decided to go what was happening, and it gave me the it saddened me, because someone told me that he had the same arc for all the treatments. So we have a 0.14 50 grams, 0.18 150 grams, 0.20 250 grams, and one single wire will develop all those forces because it has different properties. And it will start with the treatment with a 0.20 per 0.20. Why not? Why not? Because it won't slide, it won't move, the traction will be strong, so why not? Or then it will say two different arcs. The first one will develop 60 grams for the inferior arch, or 100 grams for the upper arch, depending on the places it is. The wire can be intelligent and will be smart and develop different forces. Let's say that we will start with a 0.16, which will slide less than a 0.14, and then we will carry on with a 0.18 and 0.25, and then we're supposed to be done. Why not 4 different arcs? It can start with a 0.14 with 15 grams, a 0.18 with 150, 0.50 per 0.25 with 250 grams, or we can end up with a 0.18 with 227, or even a 0.21 per 0.275. You can put a 0.8 275 on Genius bracket, but it is impossible for you to close the slot. What I'm describing here to you are the last pieces of information on the last hexagonal bracket. I'm sure that I've said something a little too much when I've said that it was hexagonal. It is possible to put in a 0.18 per 0.275, but the slot is not the right size in order to go further. So what should we do? We should respect the bone turnover and start with 20 grams. It's exactly what you've mentioned before. The 28 grams has the official version produced by Michael Way, provided by Michael Way the very first day. But since we didn't know it before, now we know how serious is our, as respectful is our provider. So we decided to test the wire, and we noticed that it wasn't 28, it was less, but it was better, even better. It was in the range of the 20 grams. So we started with a thermal ultra, and we asked Dalstra to test it, the Swiss company. And the other presentations showed it. We noticed that Dalstra provided the right studies, and thanks to the studies, we noticed that here you can see the 20 grams. Here you have 25, and we are below this threshold. So it means that it's okay for us. In the orthodontic world, it means that if you put the wire, you won't make sure that you won't push the teeth outside of the bone. Because if you use a 0.40 QNT 70 at 27 degrees, it will give 70 grams. Why is it necessary to do so if you can start at 20? it will be easier for you to start with 20. So let's go even further. The main idea today would be to say that we need to make sure that the wire can act. We need to let the wire do its magic. And then you need to carry on with 50 grams. You shouldn't forget that the point 14 can reach 60, 70 grams. 50 grams is 18 square thermal. And what I would like to show you, what Emeric showed you, is that we will start with point 14, then we will end up with the 50 grams. And here we are in the 50 grams range. It doesn't seem to work. That's wonderful. I was talking about my square wire thermal intra. I was so excited to talk about it. Here it goes. So it is a Mac, it's an Apple, it's not Windows. So as you can see, it's easier to find a solution. Here is the line of the 50 grams. We can reach the 50 grams very easily. So we reach 50 grams with 0.18 square, even if you had a 0.18 with more than 14 with more than 70 grams. We're trying to go even further. And what we'll try to do is to carry on with 75 grams of 100 grams. It's a little more than the 0.14 copper niti that we've talked about before, and it is a 0.18 per 0.25 thermalultra, 0.19 per 0.25 thermalultra. What you could do is to use one of those arch wires, depending on what you can put in. For Emeric, it is easier to put in 19.25, but for Leslie, it is more complex. So what you'll do is to start with an 1825, and it works perfectly because already now you're using a 0.18 per 0.25 all day long. But there is something which is quite particular and which wasn't really understood when we led this study with Daltra. And it is here that it happens. When we put in place the 0.18 per 0.25 or the 0.19 per 0.25, the teeth are lying, because if it wasn't the case, it would be impossible to put the wire, because the patient would be in pain. So it means that the wire is not deformed at 10 millimeters, 2 millimeters. So if here you are at 75 grams, it means that you change the shape at 2 millimeters. But if you are at 1, there is no strength anymore. The particularity of the thermal ultra at 18 per 25 or 19 per 25 is that the forces will diminish very quickly. 16 per 25 copper niti will deliver 211 grams. I would like to give you the same explanation with the 18 per 25 thermal ultra, but this time I would like to show you the deloading curves. So here, for example, in light blue, you can see that at 1.5 we are below the 50 grams, and the discharge happens very quickly. So it means that when it comes to the 18.25, it will lead to no issues at all. So to conclude this Genius Summit, I would like to tell you something. Let's say that we are presenting the new archwire sequences. It will be a 0.14 thermal ultra. And in this case, we will have a lightweight effect. Then we can carry on with a very light bird with the square 0.18 with 50 grams, and we can end up with someone on skis with 0.18 sliding between the different obstacles with 0.18 per 0.25 or 0.19 per 0.25 thermal ultra. We need to be more efficient to save times, to reduce the time of the different treatments. It was exactly what we mentioned, but at the end of the day, we still need to have a quality survey, to use panoramic X-rays, to have photos, because we need to have, we don't really know how we bonded it, we need to have the finishing touches. We can even go beyond, and I will echo what Emeric mentioned, use the indirect bonding. When it comes to indirect bonding, I would like to remind what he mentioned beforehand and reuse those photos. Thanks to indirect bonding, I can have the right quality control, and I don't even need it anymore, to be honest. I mean, soon enough, I won't need it anymore. I have integrated finishing touches in my treatment plan, and I can also reach the right precision in my treatment plan, which I can reach right away, which means that I will save time. I will use less arch wires, but more specifically, more precisely, which means that it will lead to less appointments and a happy customer. Or at least in Paris, the patient is delighted to come less. A few structures, a few facilities will still state that it is necessary for the patient to come every 4 weeks, but it's not the case anymore. Now we are living in an artificial intelligence world, and the patient doesn't need to come as many times. We are leading a time where it is necessary to integrate the treatment plan in our indirect bonding the same way as we do with the retainers. You will use a software which will provide a treatment plan for the retainers and for the indirect bonding. And I would like to echo what Ashley mentioned at the very beginning of this Genius Summit. The device that you'll use is not that important. Should you use retainers or brackets, the result is the same. You will just have a retainer in order to put the brackets in it, and it will end up where you need them to go. But be careful, because Emeric started to talk about it, and I would like to insist on that. You really need to keep on learning and to learn how to use indirect bonding and learn how to schedule it to programming, the same as the clean check. The clean check always needs to be modified once, twice, 3 times. This time you are able to do all the right changes at the right time and see what the consequences would be live. What I'm proposing is customized suit, in a way. A customized treatment plan. Let's start with a clinical case. It is a very simple clinical case. This is just for the pleasure. There is just a slight of a bite. There is a very low DDM at the arch level. You need torque, but you know that it's possible to have torque advantages thanks to our arch wires. And it is a class 1, there's basically nothing. But it is still needed to, we still need to treat because there is an exocclusion on the 15. It worked this time. I guess the remote control's working now. So there is an exocclusion, and then you provide the panoramic X-ray. There's basically nothing to do. I mean, the treatment is pretty simple. Here is the profile X-ray. You can see the superior incisal, which is proclined. But so it is quite easy. You see an FMA and brachy. And I can see what is happening. Now, it is easy because you just have to use an indirect bonding. We are still using our beveled wedges, which are necessary. They are thick enough in order to prevent the contact between the upper and lower teeth. Then we can start the treatment. The beveled wedges are still important. Most of the time we don't use ceramic brackets on the lower arch because we think that the ceramic being harder than the wedge, the upper teeth can wear and tear against the ceramic bracket. So when we start, we put in place a point 14. And since the case is extremely simple, we don't even need to let the arch wire run its magic for 4 to 6 months. We can go to the next step quicker. So after 2 to 3 months, we started to use 0.18 per 0.18. Here you can see the aligned teeth. When it comes to the 0.18 per 0.18, it was the day we put it in place. So we needed to give it time. So then we end up with the 0.18 per 0.25 with the thermal ultra, and then we need to deal with the quality control. Since we bonded everything by hand, and it is exactly what I want you to think about, and I want you to start this paradigm shift in your brain, because I would like you to imagine that tomorrow you won't need to provide as much quality control and to provide as many finishing touches, because it would be programmed, it would be scheduled in the clean check before you even start. This quality control is necessary because of the direct bonding. So here are the photos after the action of the 0.18 per 0.25. We can see the aligned teeth, of course, obviously. Here is the result when you zoom in. And you can see very interesting details because despite the stops which were put in place, of course, the system doesn't work anymore. Here we go. You can see that the stops are positioned distally with 13 and 23, but the stops drifted a little bit, and you see diastema opening up between the incisors. That's why every time you're done with the alignment, you need to provide ligature, H-shaped ligature, in order not to have opening diastema when there is a torque effect. Here is a panoramic X-ray. You can see that there is a slight issue with the 13, the 41. When it comes to the 41, don't you think that it is mostly a root issue because it is not in the same axis as the crown? Maybe we should just adjust it, but that's it. Look at what we've done with our 3 arch wires. The progression is quite fast. It's quite quick. So in France, we need to do 6 semesters in order to earn a living. So it's not logical for us to do more. We are trying to do ever more and doing so as quickly as possible in order to be as time efficient as possible. Here is the bone turnover, and it is the same with the progression of the lower arch, and we have managed to reach those results in only 6 months with the 0.14, the 0.18 square in the middle, and the 0.18 per 0.25 on the lower side of the slide. We, of course, need the finishing touches. We need those finishing touches because we managed to do manual bonding, because we didn't do it indirectly, because we need to close down the diastema which were opened. And because of this situation, it means that we need to put in place a fourth arch wires, but it's not the 5th one, so it means that we save 1. And we need to use the indirect bonding in order to have a scheduling with 3 arch wires for the treating. The fact that we need to provide H-shaped ligatures in order to be as efficient as possible. Each patient which is reaching the end of his treatment or her treatment is replaced easily by another. And it is when you're supposed to show how efficient you are. Here is the bite with the occlusion. You can see that we keep on working on it. Here we are closing the diastema of the different spaces. As Leslie explained it beforehand, I like to close the 3 to 3 spaces. Then it will be open between 3 to 4 and 4, and then we can keep on closing the chain in order to keep on closing the 3 to 3 spaces. Now we are reaching the retention, the right retention, and we will be able to add new modules in order to close down the residual places, going from the premolar hooks to the cuspid hook. There are the heel links from TP. You can also find them at Auto Partners. From 3 to 6, it is a bigger size, the module 6, and then we can take our time to just close down the spaces. It is a simple treatment without any complications. What I would like to show you today is that is a perfect segue for me to deal with the anti-bond and direct bonding, which is leading to the safety control system, which will disappear to those integrating finishing touches and to this newfound precision. How so? How come? I would like to go back to the image, the metaphor I used before, that of the customized suit because you will be able to propose customized treatment plans to your patients thanks to ready-to-wear brackets. So here is the main shift, the main change that you need to integrate. And now I would like to go back to something which is quite simple. Bilal likes to bond very high, very close to the gum. This one wants to bond very low on the teeth. I want to bond right in the middle, but it's not an issue with indirect bonding. You just have to select all the teeth that we've shown you, that Emeric showed you before. You can just put them wherever you want and see what the consequences would be, even before the beginning of the treatment. Even before you start the treatment, you can just see what the final situation would be. It is some sort of a clean check, some sort of an approval system. And it is a big change between yesterday and today, that in what's happening currently. In the bonding world, you are not bonding willy-nilly anymore. So here, for example, you can see the aligned teeth, what Emeric showed you before. It is okay for you or not, and you can adjust the situation to your liking. The patient sees that you know how to work with those kinds of situations, that you're skilled. It is important to show that to your patient. And now I would like to dive into further details. I'd really like to insist on that. I would like to talk about cuspids. So here you can see that I'm moving the bracket this way, and this way the cuspid will rotate to the right. But if I move the bracket, the cuspid will move the other way. Why do I need to modify the position of the cuspid? I need to modify the cuspid position because this cuspid has a different dental anatomy, depending on the cuspid we're dealing with. And I need to adjust to that. Thanks to indirect bonding, it is quite easy for us to adapt. The cuspid has a different shape. Yeah, that's right. And now I can quote Alain Loutrou, my big brother, because in his last book, Dental Anatomy, is not even the first one to appear on the book. It is Françoise Tilota. Why? Because he gave her the copyrights. Why? Because she got an issue. It is impossible for her to work anymore, and he decided to take the passenger seat. But what is being used in this book are digital photos that I worked on with him. I learned to use Illustrator thanks to Alain Loutrou. I mean, in a word, I have to say that I've started to work with Alain Loutrou in 1978. Ephraim, you just have 5 minutes left. 5 minutes left. But I'm done in 5 minutes, so it's okay. I would like to show him his book about dental anatomy. Here are cuspids. There are 4 different cuspids, and you can see that anatomically they're completely different. So it is impossible to bond the ready-to-wear brackets the same way on those 4 cuspids. Here is the middle. Let's say that you put the bracket here. Here it's working. Let's say that I'm putting in place a bracket with the same tilt. It won't work the same way depending on the shape of the cuspid. When it comes to the height, sometimes I'm in the middle of the cuspid, sometimes I'm not. When it comes to the crown, it is more or less high, more or less big. Where should I bond? In the middle or not? Let's say that here I'm bonding the bracket this way. When it is working, you can see that the cant is not exactly the same, depending on the round part of the shape and the anatomical particularities. Thanks to independent bonding, you can see what it will look like, and it is the best way for you to manage the cuspid torque that you would like to use on that, and you can also use the buccal bonding, buccal side bonding. So let's say that here you would like to do it in the middle. It's not exactly in the middle here in the cuspid. Would I want to be in the middle? Not really. I mean, it's just an image. I've just decided to put my brackets at the forefront. If I want to talk about real life, my bracket will touch the 2 edges, and it won't really adjust because it is a ready-to-wear bracket. It doesn't correspond to the buccal face, the buccal area, and I need to deal with it. How should I do that? It means that I will have to rotate slightly my cuspid in order for them to adjust to the situation, in order to get the right offset. So it means that the cuspid offset could be scheduled before you start the treatment. Here I decided to put a more important offset on the first one and less important one, depending on the cuspid. Or you can increase the offset by moving the bracket, and it is when you're dealing with a custom-made approach. The software will provide a very swift answer, very short answer to you. And then you can just customize everything. Why do you need this custom-made piece of clothing? Because here, when it comes to the finishing touches, which are proposed to you, you will need to deal with the mesiopalatal angle of the cuspid, which is too inward, which means that the lower cuspid will remain too much on the posterior side, and you will remain in class 2 situation. You will add elastic, and it won't work. But it's just because you need to increase the offset. And it is particularly easy to do so before you even start the treatment, thanks to indirect bonding. Not only is it easier, but here, for example, you can see that the offset distal of the molar is working perfectly by itself. Here is the tube, the genius tube, that will give you the right distal offset on the first molar. And here is the cuspid offset, which was put in place on the cuspid. It is OK, it is good to go, which means that the lower arch will be able to become a class 1. And it is the same on the other side. You see that nowadays it will be easier to change slightly little details, which will be particularly important to have a perfect class 1 with the cuspids. It was impossible to do so beforehand because we couldn't have a look at the end result before the end of the treatment. Here you can have a sneak peek of the end results thanks to this specific clean check. You can see the class 1 and the end result with the cuspid. When it comes to the bracket positioning, it is a little bit more on the mesial side, but it's OK. I mean, it's because because of the specific shape of this cuspid, it was necessary to do it this way and with a specific offset. So here I decided to dive into further details. Here you can see that the cuspid offset is put in place correctly, that the curved shape of the cuspid is taken into account correctly. And here, you need to bear in mind that you still have the possibility to use 3 arch wires instead of 4 to begin with, by respecting the forces that we would like to use, that we are able to use software for indirect bonding, which is a clean check. Which is a clean check allowing us to have the custom-made suit or custom-made dress you want at the end of the day. And then you can have the quality efficiency and the efficiency necessary, which is equal to the patient satisfaction. You will reduce the number of appointments, the amount of time spent on your chair. And now I would like to give the floor back to Emeric, because Emeric is in charge of concluding this presentation.
30 seconds. It will be short. In other words, I want you to think, to brood over this little picture here. I do not hear the speaker. The translator does not hear the speaker. It took us 15 years to get this into the sales. Am I the one on the right or one of the other two? I just want to say thank you very much.
Voilà.